Today we will have a bird's eye view of aortic stenosis and its treatment by transcatheter aortic valve replacement, which is called TAVR or TAVI. So basically, we have four valves inside our heart. The function of the valve is to maintain unidirectional flow of blood. So once the blood flows from one chamber to the other chamber, after it is entered into the other chamber, it should not come back. If it comes back, it is called regurgitation. And the valve orifice, usually the aortic valve, when it opens, the valve area will be almost 4 centimeters square. If it keeps on shrinking down slowly over a period of years, if it reaches the valve area less than 1 centimeter square, it is called severe aortic stenosis. So aortic stenosis can be because of specific conditions. So usual condition in younger people is rheumatic heart disease, whereas in older individuals, people who are more than 55 years, they usually develop what we call degenerative aortic valve stenosis, which is a wear and tear phenomenon of the aortic valve. So degenerative aortic valve stenosis is a chronic, that is slowly progressive condition. The valve leaflets keep shrinking so that the outlet of the valve keeps on shrinking. The patients will have usually three symptoms. The first and predominant symptom is dyspnea, which is the breathlessness, and then sometimes chest discomfort on walking, and then some people will have a syncope, so that is called loss of consciousness. So when the aortic stenosis, we usually grade into mild, moderate, and severe. So when the condition is mild and moderate, patients are usually asymptomatic. When the condition becomes very severe, they will start getting the symptoms. Traditionally, when the aortic valve shrinks and severe aortic stenosis happens, the traditional treatment is surgical aortic valve replacement. So we have to open the heart and then implant the artificial valve, which is done by the cardiothoracic surgeons. This is the gold standard treatment, which means this is the proved treatment. But in certain conditions, particularly when the patients are very old, more than 75 years, frail, and have comorbid conditions like kidney problem, diabetes, coexisting blood flow abnormalities like heart pumping condition on the lower side, these patients are at higher risk for the surgical aortic valve replacement. In these conditions, transcatheter aortic valve implantation is the treatment of choice. But slowly the condition is being established and done for even intermediate and low risk patients also, but that is done only in specific situations. So the classical indication for transcatheter aortic valve implantation is severe aortic stenosis in a high risk individual. Generally it is over an age of 75 years. So whenever transcatheter aortic valve implantation is done, we usually talk about four important complications you can have during the procedure. So one important complication is the stroke. Second important complication is the need for the pacemaker, because our pacemaker is near the aortic valve. So when the valve is implanted, it can get stretched or compressed, and when we implant 100 patients, 5 to 6 patients can have a need for the pacemaker implantation. So this is the second important thing we should understand. Third is the bleeding from the groin side, so femoral artery. So we go through the a big blood vessel called femoral artery in the groin, so it can have some bleeding issues. Fourth is the infection. See, these are the four important complications you can get, but still these complications are so less that the benefit is so high in individuals with transcatheter aortic valve implantation need, TAVI or TAVR. So aortic stenosis is diagnosed in outpatient department by looking at the ECG and echocardiogram. So the main imaging modality will be the echocardiogram, which confirms the diagnosis. Once it is confirmed, we will do a protocol called TAVI protocol aortogram, where the patient has to go to the CT scan department, and then a dye will be injected, and the aorta, aortic valve, and we have 3 blood vessels supplying the heart, coronary arteries. These will be studied by in this contrast induced CT aortogram. That will give us the idea of the anatomy of the valve, and if there are any blockages in the blood vessels of the heart, that has to be tackled. Most of the time it should be tackled before going in for the aortic valve implantation, or sometimes it can be done during the procedure also. So once the CT aortogram is done, patients will be counseled, attenders will be counseled about the need for the procedure, and what are the implications. The typical transcatheter aortic valve implantation, the stay is 3 days in the hospital. But if the patient has a need for a pacemaker, the stay will be increased by another 2 to 3 days. This after the procedure, usually patients will be discharged on the second or third day, and they can keep mobilizing, do the day-to-day activities without any issues in the long term. There are two types of transcatheter aortic valve in the situation. So one is called the self-expanding valve, and the other is called the balloon expandable valves. So after the aortic valve anatomy studies, we will be knowing which valve is better for which patients, but typically in 80% of the situation, both the valves can be implanted. In specific situations, only certain valves will be indicated as the most. So two important mechanism of the valves, one is the self-expandable valve and another is the balloon expandable valve.